Although the phenomenon of cortical spreading depolarization has been recognized for quite some time, it has not been until relatively recently that it has been associated with neurological injury. In 1944, neuroscientist Aristides Liao described an electrical silence that spread across the cerebral cortex. Because of the diminished activity, he called it cortical depression. As the physiology of this phenomenon was further studied, it was realized that the electrical silence was the result of sustained neuronal depolarization. With this recognition, the event became known as cortical spreading depolarization. Following brain injury, pathologic neurotransmitter release, known as excitotoxicity, results in unregulated postsynaptic cellular depolarization. This initiates a complex cellular cascade that may result in neuronal dysfunction and even cell death. Unregulated changes in the balance of intracellular and extracellular ions prevent the normal repolarization of neurons. These alterations are accompanied by cellular swelling. The cell's ability to restore ion balance and reverse these changes requires the function of ATP-dependent ion pumps. In conditions that are often accompanied by cerebral hypoxia, such as traumatic brain injury and ischemic stroke, this is even more challenging as the brain must use anaerobic metabolism for its energy needs. Cortical spreading depolarizations have been seen in a number of pathologic conditions, including traumatic brain injury, aneurysmal subarachnoid hemorrhage, and stroke. The wave of depolarization spreads at 2 to 6 millimeters per minute. This appears as a prominent negative change on extracellular recordings. A destructive neurovascular response may be associated with the spreading depolarizations. Normally, increased neuronal activity triggers an increase in local cerebral blood flow. Initially, the spreading wave of pathologic depolarization causes a hyperemic response. Even when hyperemia is present, ischemia can still occur if energy demand is not met. Although the hyperemic response often outlasts the spreading depolarizations, it may be followed by a period of vascular unresponsiveness called spreading oligemia. This can last for up to 2 hours and contribute to cerebral ischemia, especially in tissues with high energy demand, such as those in energy crisis. The next step in preventing damage from cortical spreading depolarization comes in detecting the presence of this condition. Routine surgical placement of electrode strips across the cortex may not be practical for this patient population. Recently, however, it has been shown that a single depth electrode could be used for diagnosis. Cortical spreading depression can be seen in a variety of common brain insults. Neuronal injury can occur even in the absence of increased intracranial pressure or global cerebral hypoxia. In the future, real-time detection of cortical spreading depolarizations will be an important factor in treating this condition.